Okay, so in this presentation, these are the objectives we'll aim to achieve. Would like to highlight the high burden of cancer of the esophagus in this region, and would also like to highlight the various treatment modalities and their benefits, and especially compare to see out of the various modalities available, which ones do we have at our disposal in this region. And then I hope together we'll explore strategies towards prevention of cancer of the esophagus and strategies towards early detection of the disease. I'll start off with sharing a bit of the global burden of cancer of the esophagus. And cancer of the esophagus ranks the eighth most common cancer worldwide. I think of all the cancers that there are in the world, cancer of the esophagus is number 8. And it is the 6th most common cause of cancer-related deaths. Put together all the cancer deaths in the world, cancer of the esophagus is number 6 in contributing to that number. But even this does not accurately reflect geographical variation in the occurrence of the disease. Much of this burden is concentrated within a small part of the world, really. Actually, 80% of cases of cancer of the esophagus and deaths from cancer of the esophagus occur in the developing countries. And not all the developing countries, actually. This 80% again affect just a small proportion. Cancer of the esophagus is one of the cancers with quite distinguished geographical distribution. There are particular hotspots in the world for cancer of the esophagus. And so majority of this 80%, even in the developing world, is limited to these geographical hotspots. There are actually 2 cancer belts, one in the Asian countries, China, and we'll see China, Iran, and a little part of South America. And then there is a belt for cancer of the esophagus along the coast of Africa, along the eastern coast of Africa. So majority of this 80% of cases and deaths are actually restricted to these geographical hotspots. And that means the overall burden in these areas is quite significant. So the areas, the geographical hotspots I've already mentioned is a small part of northern China, northeastern Iran, a small part of South America, and then the eastern coast of Africa, ranging from Ethiopia, Kenya, Uganda, Rwanda, Burundi, down to South Africa. These are the hotspots for cancer. And notably, the burden of cancer of the esophagus is much less in West Africa, Western and Northern African countries. They have a significantly lower burden compared to this eastern coast of Africa. So in this slide, you see the areas marked with deep colors, beginning from Ethiopia, South Sudan, Kenya, Uganda, Tanzania, down, this eastern coast of Africa. That's really a geographical hotspot for cancer of the esophagus. And I quote this from the Global Cancer Network. In 2020, cancer of the esophagus ranked number 6, and that's what we mentioned above. Number 6 among the leading causes of cancer death. That follows lung cancer, colorectal, liver, stomach, and breast. These are the ones that contribute more than cancer of the esophagus. And in Uganda, being among the high burden countries, cancer of the esophagus actually contributed, ranked number 3 among the contributors to cancer-related deaths, top on this list is cancer of the cervix, Kaposi sarcoma. Then number 3 is cancer of the esophagus. This is still according to the Global Can report of 2020. And among main in Uganda, cancer of the esophagus still ranks 3rd. Among the Kenyan main, cancer of the esophagus even ranks higher. It is the 2nd leading cause of cancer-related deaths. Notice that Kenya is also within this geographical hotspot. So this shows how big the burden is. I will discuss this additional data for Uganda. There are these 2 studies which were done. One is a study published by Nelson Alema et al. In 2014. So in this study, Nelson was investigating the histological subtypes of cancer of the esophagus in northern Uganda. And as expected, esophageal squamous cell carcinoma ranked highest. I think less than 5% was adenocarcinoma. But in this study, he found that out of 1,800 patients who presented to their endoscopy unit, 7.5% of them actually had cancer of the esophagus. You can work out the mathematics, that's a significant number. And again, Bine published a study in 2021 where he looked at the patients presenting to the endoscopy unit of Mulago National Referral Hospital. He particularly looked at patients presenting with dyspepsia, and he found that 11% of these patients, of the 159 patients that fitted in the inclusion criteria, actually had cancer of the esophagus. So we can see 7.5, 11%. And I will share our own statistics from Chabira Surgical Center. Our endoscopy unit has been in existence for 3 years. And recently we looked at how much cancer of the esophagus contributes also. And we found that out of 500, about 520 patients that have gone through our endoscopy units for various reasons, cancer of the esophagus contributed 21% of the overall number of patients who went through. So actually cancer of the esophagus, here marked in red, is the leading pathology found among the patients who come to the Chabira endoscopy unit for endoscopy. It only follows the ones with normal findings, but think of any pathologies that are found on endoscopy. You know, there is hiatus hernia, achalasia, inflammatory conditions, you know, ulcers, gastritis, esophageal varices. Among all these, you know, whatever pathologies, cancer of the esophagus is the commonest among found on endoscopy among the patients who present with us, and it contributes up to 21%. If I compare 7.5 for Alema et al. in northern Uganda, 11% from Dr. Mbine, this is quite high, up to 21%. And I would be asking the question, since Alema's study was 2014, Mbine 2021, and this is a report from 2022, could it be an increasing pattern? Maybe not. Could it also be that actually this region, the Busoga sub-region, has a particularly higher burden than the other parts of the country? That is a possibility. But cancer of the esophagus is the leading pathology among patients in our endoscopy unit. So this really represents quite a high burden of the disease. We'll look at the risk factors. What are the possible risk factors for the disease? Patients commonly ask, what causes this disease? What can I do to prevent catching this disease? Unfortunately, we don't have known causes of cancer of the esophagus, but there are a number of risk factors that have been identified. And here we go through a few of them. Genetics is one of the most important risk factors if cancer of the esophagus is determined in our genes. In America, in the US, it is known that the black male are 6 times more likely to get cancer of the esophagus than their white counterparts. That points to a genetic predisposition. You know, these people living in the same environment, probably eating the same food, maybe having similar lifestyles, but the blacks are still 6 times more likely to get cancer of the esophagus as compared to the Hispanic or the white counterparts. So that points that there must be a genetic predisposition. Geographic or environmental factors most likely contributes. That is why we talked about the geographic hotspots for cancer of the esophagus. Alcohol and smoking, non-risk factors for many cancers, and cancer of the esophagus is not an exception. Alcohol increases the risk by probably 2 to 9 folds. Smoking increases the risk by about 4 folds, I think. Foods, it is thought that most likely there are things we eat in food that predispose to cancer of the esophagus. The last 3 factors are even more interesting. Indoor wood combustion has been studied. You know, in our typical villages, we live in huts where one hut is the kitchen, the living room, and the bedroom in some cases. So that means we cook where we live also. And that concentration of smoke in our houses without any provision for good ventilation is thought to be a high risk factor for cancer of the esophagus. And this has been studied by a number of people. Machiro et al. Reported a study in which they isolated, you know, they identified people who live in conditions where there is indoor wood combustion, and they found that there is some correlation with cancer of the esophagus. Thermal injury from hot foods and beverages. I think in East Africa, generally, people take tea a lot. And again, Machiro et al. Tried to investigate this factor, asking the question, how much does taking hot tea and hot foods correlate to cancer of the esophagus? In their study, they did not identify a significant relationship between taking hot tea and cancer of the esophagus, but they identified that in this area with a high burden of cancer of the esophagus, people generally take tea at a higher temperature than that reported in other places where effect of heat has been studied on cancer of the esophagus. I think the average temperature people take tea at is 72 degrees Celsius. That is more than 10 degrees than in other places where high burden of cancer of the esophagus has been reported. They concluded that there is need to investigate this matter more. And then the polycyclic aromatic hydrocarbons, they isolated some PAHs in tea, commercially available tea in Western Kenya. And they also established that there was a positive correlation between some of these PAHs and cancer of the esophagus. I'll make a brief mention of symptoms. Asymptomatic is probably one of the commonest symptoms of cancer of the esophagus, and that is a negative factor. Majority of cases of cancer of the esophagus will be there without any symptoms completely. Patients will be there normal, and the disease will be discovered during investigation for other causes or during, you know, routine endoscopy where it is done. So majority of cases are completely asymptomatic. You will be there, the disease is growing, you don't feel anything. In late disease, dysphagia is one of the most well-known symptoms, difficulty in swallowing, initially solids and then eventually liquids as the tumor grows to block the lumen of the esophagus. A number of patients will have only non-specific symptoms, heartburn, dyspepsia, cough, and weight loss in advanced disease. I've not gone so much into the rest of the symptoms. So what investigations can be carried out in cancer of the esophagus? I have looked at two, I've categorized the investigations into two. One, investigations that are done to confirm that this is actually cancer of the esophagus. Those are the diagnostic investigations. Then 2 investigations that are done to determine how far or how much the disease has spread in the body, if it has been confirmed. So those are the staging investigations. And here I have put both groups together. Barium swallow used to be, I think, the only investigation tool at hand for so long. Endoscopy has been available for not so long with us here. So we used to rely on barium swallow, where you use a contrast, take an X-ray, and then look at any irregularities in the lumen of the esophagus. We all know that barium swallow, its diagnostic capability depends so much on the person interpreting the image. And like many of the imaging investigations here, it can only suggest the diagnosis, but it cannot conclude on the diagnosis. CT scan will show a tumor irregularity in the esophagus. MRI, importantly, is endoscopy, which is, I think, for quite some years now, the availability of endoscopy is increasing in Uganda generally. Unfortunately, most is still available only in the urban areas, especially Kampala. But endoscopy has the advantage of giving good visual, a good view of inside of the esophagus, a good visual representation of a tumor if it is there. But importantly, it also gives you the capability of taking a biopsy when you find a lesion inside, unlike the imaging investigations. So endoscopy plus biopsy, when indicated, is one of the most important investigations for cancer of the esophagus. I've included here the esophageal sponge. There are a number of techniques that utilize a sponge. There is a cytosponge, I think esophageal cup. There are a number of techniques. They are similar in that they all utilize a tablet, something that you swallow, which is attached to a string. You swallow it inside, but the string remains outside the mouth. And after swallowing it, I think there is a prescription of how long you should leave it inside. Then you have to retrieve the tablet or whatever you've swallowed. You have to retrieve it using the string, pull it back, and this brushes cells from the esophagus, and this can be used for analysis to make a diagnosis of cancer of the esophagus. Now, this is of a great importance because it is something that can be administered by an individual. So it can be used for community screening, unlike endoscopy, where it needs a specialized endoscopy unit, maybe with some form of anesthesia. I've added Lugol's iodine here. It is an important addition for screening endoscopy. When you do an endoscopy, there's a technique where you apply iodine all through the esophagus and then look for areas that do not take iodine adequately. These are suspicious areas for cancer, and this can direct your biopsy. It can help see even small lesions better, but then it can direct where to take biopsies from. Lugol's iodine has been studied, used with endoscopy, and is quite effective in identifying esophageal lesions. It could increase capabilities to identify early lesions or early cancer of the esophagus. But even if it has that capability, it is important to note that screening should be accompanied with an intervention. It is not worthwhile doing widespread screening, identify lesions, and then do nothing about them. That is why I've included the last point here. Histological subtypes of cancer of the esophagus, I believe we are familiar with them. There is adenocarcinoma, which largely occurs in the distal esophagus, and it is a disease that progresses from Barrett's esophagus. And then the second histological subtype is cancer of squamous cell carcinoma of the esophagus, which mainly affects the middle third of the esophagus and sometimes the upper third of the esophagus. So I'll just make mention of this. Staging is simply determining the extent of spread of the disease in the body. It's answering the question, how much has this cancer spread within the body? And there are these three types of staging: clinical staging, mostly utilizing imaging; pathological staging, if a surgery has already been performed, then the pathologist looks at the sample and that can help for staging. Then post-neoadjuvant staging, that is staging after a patient has already received some form of treatment. And to summarize staging, this is a histology of the esophagus, the epithelium, the lamina propria. I will not go through the details of this. And the T staging of the disease depends on the depth that the disease has penetrated to. There's TIS, where cancer is limited to the epithelium. There is T1, where cancer is extended to the submucosa, and beyond that, T2, T3. T4 is when cancer is actually extended beyond the adventitia of the esophagus, and probably it has involved other structures in the chest. And also there is the nodal staging, whether or not lymph nodes are involved and how much lymph nodes are involved actually. So there is N1, if 1 to 2 lymph nodes are involved. There's N2, there's N3. I'll proceed to management of cancer of the esophagus. And I should mention that management is largely dependent on the stage of the disease. So when management decisions are being made, the stage of the disease is priority. But before we get to that, in management, I have importantly included prevention and early diagnosis. So in prevention, what can we do to prevent cancer of the esophagus? We looked at the risk factors above. It looks like prevention is not an easy task. Some of the risk factors, food. I think food that we eat, if it has possibility of, putting us at risk of cancer of the esophagus, we are not likely to stop eating. There is taking hot beverages, which is quite a practice in many places. Genetics, of course, there's nothing we can do about. So it looks like many of the factors associated with cancer of the esophagus are not exactly easy, but I put this here so that we can run it through our minds and think of what can be prevention strategies for this disease. And then early diagnosis is quite an important part of management. If we are able to detect the disease early enough, then we are likely to treat it more successfully and more easily. Are there strategies that can help us to detect cancer of the esophagus early enough? I have put here community surveillance. So a number of studies have been done in high-risk communities where people have proposed to do widespread surveillance endoscopy among high-risk communities. This is quite a good strategy. However, even in high-risk communities, the yield has not been so much. So you find that you may do 100,000 endoscopies, but maybe catch only a small number of early lesions. At the end of it all, you ask what is the cost, benefit analysis of this an approach. So widespread community surveillance has not been widely recommended because of the cost benefit analysis. But of course, I think we can argue for even a very high burden like what we have seen up there. Most likely widespread community surveillance can be justified. But we'll see down, if we are going to do community surveillance, then what intervention do we have in place? Because it is worthless to do surveillance, identify early lesions, and then not be able to do anything about. So we'll look at treatment options for the disease. Treatment basically depends on whether it is early disease, whether it is a local regional disease, or whether it is metastatic disease. So if we catch early disease, the approach will be different from when we catch locally advanced disease, and then when we catch metastatic disease. Treatment of early disease. By early disease here, we look at tumor that is localized to the epithelium. We look at T1 lesions that only extends to the lamina propria, and then we look at T1b lesions that reach the submucosa. So early disease is disease that does not go beyond the submucosa. It does not involve the muscular wall of the esophagus. For early disease, endoscopic techniques are quite applicable, and they have the advantage of being minimal invasive, yet very effective. The two endoscopic techniques that have been employed are endoscopic mucosal resection, where you identify the affected mucosa and resect the whole mucosa. There is also endoscopic submucosal dissection, which lifts off the mucosa with its attachment submucosa, attached submucosa. Dissection is carried out in the submucosal plane, and the disease is resected en bloc with normal tissue. I guess we'll ask the question later, and I'm glad we have Dr. Kawero here. This modality is available in country. Most likely we don't have them available with us. I've put down here cryotherapy and radiofrequency ablation, which I will come to later down. These are two treatment modalities that are applicable both for early disease and also for late disease. This is an image showing endoscopic submucosal dissection. In image A, you see these mucosal nodularities that has been identified. In B, they use the electrocautery to mark the area where the resection will take place. You see there is up and down, lower in the esophagus, and then the dissection eventually in F, the affected mucosa has been successfully removed. This is minimal invasive therapy, and so much benefits if we can catch early disease and if we are able to intervene in this manner. Locally advanced disease, T2, T3, and varying nodal status. So T2 is when cancer has spread to involve the muscular wall of the esophagus, and T3 is when it has even reached the adventitia of the esophagus, but when there is still no distant metastasis. In this case, the overall treatment is esophagectomy. I believe many of us may have seen esophagectomy being performed. So that is what is the mainstay of response for T2, T3 disease. But a number of trials have been done which have established so much benefit of pre-operative treatment, neoadjuvant treatment before surgery. There is the CROSS trial, there is the MAGIC trial, the CAL-B trial. All of them randomized patients to pre-operative chemoradiotherapy and surgery only. And there was overwhelming benefit to pre-operative treatment before surgery. So when we identify any locally advanced disease, the wise strategy is to give pre-operative chemoradiation to shrink the disease, then proceed with esophagectomy. Again, the details of and approaches, the types of esophagectomy I'll not go to, but for locally advanced disease, T2, T3, that is the main stay of treatment. And then the third category is metastatic disease, when cancer has spread to involve other structures in the chest, maybe the pleura, the great vessels, the pericardium. Surgery is not an option, or is not the primary option. There is limited role for surgery. So in this case, the mainstay of treatment is chemotherapy and radiotherapy. There are various regimens that have been studied and utilized. In addition, there is also the option of immunotherapy. There are a number of immunotherapeutic agents that have been studied and approved for use. The advantages with immunotherapy is most times they are more tolerable side effect profiles as compared to the various regimens of chemotherapy or radiotherapy, but both available options for metastatic disease. So as I mentioned, there is mucosal ablation techniques, basically cryotherapy and radiofrequency ablation. These are techniques that have been utilized for both early disease and also for late disease. There is cryotherapy, which is the use of liquid nitrogen at very cold temperatures, I think up to -196 degrees Celsius. So liquid nitrogen at these cold temperatures has been successfully used to treat the early disease category that we saw above, but also for late disease. So it is an endoscopy-based treatment where through the endoscope, you identify the lesion and then spray with this cold, super cold liquid nitrogen. It has been shown to bring about satisfactory regression of disease. It has also been employed in advanced disease, you know, the obstructive lesions of the esophagus. This is an example. In B here, you see there is a malignant stricture of the esophagus. The lumen is almost fully blocked, but after applying cryotherapy, the lumen has been satisfactorily opened. And a study revealed that use of cryotherapy can actually prevent progressing to the stage where someone needs stenting. And if it doesn't prevent completely, then at least it delays the use of stenting. Stenting comes at later stages, really. And stenting seems to have more adverse effects than cryotherapy. The same cryotherapy is also used for treating the early lesions of the esophagus, as we saw above, quite satisfactorily. There is radiofrequency ablation, which is using hot catheters, catheters that are heated to high temperatures and directed to either the early lesions or again the late lesions of cancer of the esophagus. And this destroys the cancer cells. And the radiofrequency technique ensures that there is destruction of tissue only to the level of the lamina propria, so that tissue can regenerate quite easily. Those are quite important tools because they are minimally invasive with less burden on the patient. So these are the treatment modalities available for cancer of the esophagus. Before we conclude, there are also palliative surgical procedures. We are familiar with a number of them. Of course, when the patient cannot swallow anymore, we usually put feeding gastrostomy to aid in the feeding. I think a number of us may know the many complications of feeding gastrostomy. Usually, you know, the surgery put a feeding tube in a patient who is already so malnourished. Many times the site breaks down and it can be a difficult scenario to manage. Of course, there used to be the Celestine tube when there is an obstructive tumor, but there is still room to pull through a tube, which keeps the esophagus patent. Many complications, migration of the tube, not very satisfactory. What has been used quite satisfactorily, stents, esophageal stents, the self-expandable metallic stents have been used quite satisfactorily, and they are quite available with us right now. I think it's available in many places, in Kampala, in Jinja, also at our center is quite available. It has its many associated comorbidities, but it's quite a reasonable tool at hand. And here is a image of, on the left, an obstructive tumor of the esophagus, quite friable as you can see, but a self-expanding metallic stent has been placed, and it has successfully opened up the lumen of the esophagus. Patient can once again feed and maybe gain some weight in preparation for chemoradiation. Stenting is quite a handy tool for patients who have tracheoesophageal fistula. On the left, you can see a barium swallow with barium spilling into the bronchi, really, into the main bronchi. So this patient had advanced disease with tracheoesophageal fistula. On the right, a stent was placed, and as you can see, the involvement of the lungs has resolved. So the stent has successfully given palliation for the tracheoesophageal fistula. In conclusion, we live in a high burden area, quite an endemic zone for cancer of the esophagus. And unfortunately, even with the high burden, we have very limited modalities of treatment of cancer of the esophagus. Among all the modalities we have looked at, I think we have treatment for locally advanced disease available. That's esophagectomy, plus chemoradiation, which is both for neoadjuvant therapy in locally advanced disease, and also for treatment of metastatic disease. So that is a modality available with us. I think we don't have the endoscopic mucosal therapies. We probably don't have cryotherapy, radiofrequency ablation. We don't have those modalities with us. So while we live in a high burden area, we have very limited modalities for treatment. And the question is there room for expanding, broadening our treatment options? I hope there will be room. And about community screening, whether using endoscopy, oral, esophageal cap, oral, whatever modalities. I believe high as our burden is, this should be a reasonable approach. Unfortunately, we don't have intervention measures if we identify early lesions in the community. The WHO strongly recommends that any screening measures should go hand in hand with intervention. It would be so stressing for the patients for us to do screening, discover early lesions, but we can't do anything about it. We simply watch them grow. So I think that is where our gaps are. I hope in the future will come when we have, capabilities to intervene for early lesions when discovered. That will justify and make us able to do widespread community screening. Thank you. This marks the end of my presentation.